Hello, and thank you for joining this OncLive peer exchange titled Nuances in Treating Advanced Lung Adenocarcinoma. As we continue to see progress in development of new therapies for advanced lung cancer, we also endeavor to refine the use of systemic therapy. In this OncLive peer exchange panel discussion, I am joined by a group of experts in the field. Together, we will help you to navigate the ever-evolving landscape of treatment options and the nuances of integrating newly approved agents and new indications into current practice patterns. I'm Dr. Mark Socinski, and I'm the Executive Medical Director at the Florida Hospital Cancer Institute in Orlando, Florida. Participating today on our distinguished panel are Dr. Ross Camidge, Professor of Medicine and Oncology in the Joyce Zeff Chair in Lung Cancer Research and Director of Thoracic Oncology at the University of Colorado Cancer Center in Denver. Dr. Mark Kris, the Rowan Chair of Thoracic Oncology, Memorial Sloan Kettering in New York, New York. Dr. David Spiegel, the Chief Scientific Officer, Lung Cancer Research Program Director at the Sarah Cannon Research Institute in Nashville, Tennessee. And Dr. Jared Weiss, Associate Professor of Medicine and Section Chief of Thoracic and Head and Neck Oncology at the UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina. Thank you for joining us. Let's begin. I want to start with an evolving therapeutic paradigm. 2 years or so ago, we had the initial approval of nivolumab as the first immunotherapy agent approved. And then approximately 8 months ago, we saw some very exciting data selecting patients by PD-L1 expression that were very high expressors, greater than 50%, in a very well-conducted phase 3 trial comparing pembrolizumab to standard platinum-based chemotherapy. So Dr. Kris, give us your perspective on that.
So this trial was really a game changer. I think the first thing is it led to the need to test every single patient with squamous cell lung cancer and adenocarcinoma to see what their PD-L1 expression is. The next thing it did, it showed that for people that had high degree of PD-L1 expression, about a third of the patients, that those people had, I'll call it the trifecta plus. They had better rates of response, greater progression-free survival, better overall survival, and a substantial decrease in the degree of serious side effects. I mean, never before have we seen that. The other critical piece of new information is that these people not only had good responses that were very durable, and some people did not seem to recur ever, which is really amazing. And that's the good news. That's roughly a third of the patients, and then there's the 2/3, and we'll be talking about them as well. But this trial was really a critical one. It's a fundamental change in care, and I think every oncologist now has to do PD-L1 testing every patient with adenoid squamous carcinoma.
I completely agree with you. We do it reflexively at our place. I think that's the way it should be done. It's a simple immunohistochemical test once you set up the platform. Many oncologists are sending it out. We do it internally, so I think you have to work out that sort of system. Let me ask you this. We know that Keynote-024 enrolled or screened, whatever you want to call it, 1,925 patients. Only 305 were randomized. If you do the math, that's 15.7%. Mm-hmm. So even though about a third of 30% were greater than 50% positive, there are lots of contraindications to using that. So is this really applicable to 10 to 20% of the average oncologist population in lung cancer?
It's hard to say. I mean, I think most oncologists would say, I'm not sure what average is anymore. My office is not average. I think, though, the magnitude of the benefit is so compelling that it's vital to offer that option to people that have it. How it relates to the whole population, I think that we're going to see many, many more trials that try to tell you what the real world situation is going to be. But I think testing it and, just as you say, doing it reflexively, and just a shout out to the oncologist, you have to meet with your pathologist and make sure that it's clearly explained why you need this test. This isn't some kind of crazy prognostic marker that may mean something. This is a very important test.
This is actually one immunohistochemical test we want them to do.
Right. Well, They're unbelievably skilled people, and they're really skilled in doing those tests. But I think it's important, though, that they want to be part of important decisions in care. This is a great opportunity for them to do that. It adds to their armamentarium of the things that really make a difference for patients. But you got to talk to your pathologist.
Right.
We now do this as a reflex test at my place. Any non-small cell lung cancer, squamous or non-squamous, at the time of diagnosis gets a PD-L1. And the cell to achieve that was that this is like the ER of lung cancer, that you need this for treatment decisions.
Yeah, well, one of the issues that we struggle with is that many of our patients are diagnosed initially with bronch or EBUS or something, and they have FNAs. And we know that the PD-L really is only validated on core biopsy material. I actually don't know what the status is of doing a PD-L1 testing on something other than a core biopsy. Any experience or thoughts?
It can be done. Just as you say, it's an evolving field. There's much less data out there, but you can do it. It is part of our standard armamentarium now, and every patient gets it. By the way, every patient that we have also gets ALK-IHC and EGFR L858R IHC.
I mean, to be clear, that whilst you can do it on lots of specimens, because it's a proportion score, so there's a certain amount that has to, the more of the tissue you're looking at, the more accurate it is. For ALK-IHC, one cell being positive conceivably could be enough. Yeah. So I do think in cytology, where it's not just positive or negative, it's positive above a certain level, that as you say, is still a work in progress.
Yeah.
Are any of you pushing for cores over FNAs for patients for this reason? Has it changed your biopsy practice at all? I'll confess it hasn't changed mine at all, despite recognizing the lack of real validation in FNA.
Well, I've had a couple patients over the past couple of weeks in which the initial material obtained by FNA was less than optimal. Let's leave it at that. So when you go back and have to do a second biopsy, we've been a proponent of trying to say, can you do both? Can you get a core safely, and can you get some FNA, so we get plenty of material to do this?
But the EBUS too, though, it's very often a collection of cells, so it's not just a few single cells. So they collect it in a medium, they spin it down, so there is more of yes, it's not physiologic, as it were, but they're able to do what you said there, Ross. They're able to give a proportion score.
So I want to explore one issue. One is, I believe at the time that they reported the KEYNOTE-024 data, and I do agree that the survival was very impressive in favor of single-agent pembrolizumab, I think only about 45% of the patients on the chemo arm had crossed over at that point. Obviously, this will evolve over time. We'll see. We may be seeing some updated data soon. Any thoughts about that? In terms of sequencing, is there something special about giving immunotherapy in the strong expressors first? Because the data in KEYNOTE-010 in the high expressors was actually also pretty good in the second line setting after chemo. Any thoughts?
Well, I think, at least a tenet of oncology when I went to oncology school is you give your best drug first.
Yeah, I went to the same school.
Yeah, and you give, and even better, you give your most efficacious drug and your least toxic drug first. I mean, that's the reason to do it. Yeah. Does it mean that people couldn't have benefit later on? Of course not, but you want to give the best drug first.
And crossover in the real world is not perfect.
It's not going to be 100%.
Certainly not.
Yeah.